to one of the last but one. What am I doing in cataract surgery this year? There cannot be a better person than Gaurav, who has been adapting and changing so fast. I've seen him, and every time he picks up new technology, new ideas, and he's brilliant. Gaurav, we are looking forward.
Thank you so much, sir, and grateful for being included in this session. So it's an honor and privilege to be speaking with all of you. So I'll be sharing a few things that I'm doing differently this year. And I'll take you back to a very old video, which I had to actually find. It's not mine, but this shows why I am doing what I'm doing differently this year. Using this kind of a blade for the side port in the past. I mean, I hope many people don't use it today, but it actually ends up giving you have no control on the size of your side port. You could have 1 mm, a 1.5, a 2, and actually you can have situations which I'll just take you to now. So when operating with such a situation, I think that one slide is missed, but anyway, so it can lead to a surge, and that can, because you have a leaky side port, you will never have a very stable chamber, even with the best of machines that we have our hands on today. So what's really important is to have your side ports. We always focus on the main port because we ensure that it's perfectly fitting to the size of a phaco handpiece. But we pay little attention to our side ports, and we are going to use a chopper. We are going to use infusion handpieces, and here we are showing this chopper, which you can see that I've improvised this chopper to be fitting my side port, and yet you can see that it's still leaking a lot of fluid. Now, this chopper is basically designed in such a way that it can occlude the side port to a large extent, and yet you see that the side port is leaky. So we had to innovate and improve upon this as well. Just having a chopper which is made in this way, which is improvised to occupy much of the side port and occlude it, is not going to help. So we innovated further on this and went on to another situation where we've calibrated our side ports. Dr. Rohit Prakash has done pioneering work. We experimented with 23 gauge, 22 gauge and 21 gauge MBRs, and matched the infusion and aspiration handpieces and customized them to match this size. And finally, we realized that we do have, very good side ports now, which match our instruments completely. Not only the chopper, but also the infusion handpieces, which are customized to fit these. So we have 22 and 21 gauge side ports, and 23 gauge as well. All three sizes are, possible. And you can see now that the leakage is almost negligible, and you can work at very low IOPs. You can work at less than 30 centimeters, and Dr. Vasavada will understand what I'm saying. He likes to operate among other people at very low IOPs. So this gives you excellent chamber stability during your surgery, and you can actually minimize surge even in the highly myopic eyes and other eyes which are prone to a surge, the RK eyes as well. And this helps, improve your surgery. Now, the other innovation that we looked at was, we can I'll go on because I want to cover up more things. So I'll take you to some of the other things which we innovated and added. Now, this is an old video where I love to do a jet polish. Sonu Goel spoke on very nicely on PC plugs. Here I'm using just an infusion handpiece from the main port, and I'm not touching that area. I'm just doing a jet polish. I like to call this as a jet polish. Now, you cannot do this from the side port. You have to go from the main port, or if you go from the side port with infusion, you have to keep the main port open with a second instrument like a Tyler or something, and set up a fast flow. Now, this is one of the most atraumatic ways of cleaning PC plaques, resistant cortex, stuck in the periphery of the capsular bag. And this helps in making sure that you get it nice. Now, we innovated further, and the handpieces which we designed for the calibrated side ports, we've now made them, sandblasted. And both of them, as you can see here, are very finely sandblasted, the infusion piece and the aspiration piece. And this works really, really well. Here I'm showing you another video of another technique I used to clear off the PC. Now, I call this as nibbling the PC, because there are certain plaques which, after you've done that jet polish, will still not go away. So I'll just kind of chew on the PC and do a polish. It's like a vacuum cleaning, and you can just remove those resistant plaques. Nothing else works. You can keep polishing them as much as you want. You can keep doing a jet hydro polish, but nothing works. So with a lot of control and low vacuum, you can actually go do a PC polish. And although I'm not using special settings for this, but it ends up giving you a pristine, clean PC. Yes, you have to be extremely careful, and you can see that it works well. Now here, a very resistant plaque. So a black cataract, vitrectomized eye, sonular dehiscence, and this patient was having, is a one-eyed patient, delayed his surgery by almost 7-8 years because the fellow eye has no vision. Till he could see even his hand, he did not want to be operated. So it was going to be a challenge. And we decide to stabilize the bag with capsular hooks here. And once that is done, it's a very, very challenging hard brown cataract, and with very little glow there. And once we have somehow, managed this very hard cataract, and we are left with a bag like this, you can see a dense PC plaque and lot of plaques all around, and it's a challenge to get these out. So we have to make sure that we get these out. So here comes to help. I'm initially trying to just peel them and aspirate them and using the regular ways of doing it, and struggling for almost 2-3 minutes. I could only clear off a small 1 quadrant or even less than that. And it was very dangerous because the bag was subluxated and was moving with every time that I was trying to peel the plaque. So here comes to rescue the jet polish, as I told you, and I will now use these special sandblasted calibrated handpieces and show you how we can, do a very fast and accelerated way. So I go from the main port, no aspiration, only infusion, and a jet polish over there. I'm going in those areas, and they help loosen up these very resistant plaques very, very easily, right up till the equator of the bag, where you will not want to go and aspirate. And once you can, loosen all these up, you can then very safely go with your aspiration. Because now I'm doing it from the side port, as you can see, and keeping the main port open to allow the fluid to egress at a very fast pace, so that it's working like almost like a, a jet, jet fluid wash. And now you can see that I can aspirate it so easily and effectively, and within seconds I could actually remove it. Now, once I have all of these out of the way, remains the PC plaque, which needs to be peeled, as Sonu mentioned, and you can then go and create a plane. And then you can, if once you've created a plane, you can gently peel them. Now, this is a vitrectomized eye, so the capsule is very, very friable, but it still works. And you can actually manage to still get a very nice PC clear of these plaques, and peel them very gently. You have to keep changing the forces. So you have to keep changing your position. You can go from the side port, and then you can go from the other side port, and you can go from the main port, because you have to ensure that you don't actually break or create a zonular dehiscence in these very, very difficult bags. And you can see that I'm changing my forces of moving the microrhexis forceps. And now I'm going from the main port because I need access in the other direction, and then going to peel this very resistant one-eyed patient with this plaque. And I didn't want to leave this PC plaque there anyway, so I managed to somehow get it out of the way, and there it's gone. So taking you to one of my last innovations that I want to share today. And this was a patient with the ICL, both eyes done about 8 years back, and came back with this lady during the lockdowns, had come with an attack of uveitis in both eyes, very severe uveitis, and was managed, and then lost to follow up again, came back with an intumescent cataract, and we had to go up for a surgery, and we wanted to stain the capsule. So we made these side ports, and you've seen a PI here, which was done during the time she had an iris Bombay. It enlarged so much later on. Now I'm doing a hydro maneuver for removing this ICL from the sulcus, because I don't want to use viscoelastic yet. I want to stain the capsule. So I want to retain the only fluid in the eye, like BSS. And I will then maneuver this ICL out of the bag, which I'm able to do gently under fluid itself, under infusion. And it's not difficult to do once you get a hang of it. I have been doing hydroimplantation of ICLs and IOLs for long, so I'm quite used to handling lenses only under infusion. So you manage it out of the bag, and then you go and stain this capsule under the ICL. And you can then, once your staining is done, then you can put viscoelastic, wash out, and get this ICL out. Now, all that went off really well, and I was able to do everything nicely. And now I'm going to do I'm planning to do a decompression of the lens. It's an intumescent one. So I want to just make sure that this lens is, and there you can see what happens. In spite of all my efforts, I got this situation where, this was to the rhexis loss. So for the second eye of this patient, we decided to actually go ahead and do a femto-assisted surgery. And this becomes really nice. You can do a planning. Basically, your landmarks have to be. So I'll be over in 30 seconds now. So you have to put these incisions right. And with the femto-assisted, you have to basically, the laser will not detect the anterior capsule very well. So it will have to actually end up detecting the I think I skipped the part where we were showing the part of, I'm so sorry, but I'll just run you through that. We are getting the landmarks right over here, and then positioning. And here we can see that you have to get all the positions of the settings right. And then once you fire this, you can actually get a very, very safe capsulotomy. and you can get away. So I think I'll stop. The message is clear that you can do a great job with these, and this has become a preferred technique where possible.